Good morning, everybody. I apologize for the little delay there. We had a little technical issue. It's all worked out now, so I appreciate your patience as we wait. I just wanted to give a brief introduction here. We're going to be talking with Greg Baker of AffirmedRx, and I'm really excited to have him here to talk with you about the pharmacy benefit management issues that are listed below. This year, this theme has emerged of I only do business with people I trust. And I have to say that this man has really earned my trust. And I think that you're going to understand why in just a few minutes. So I'm going to hand things over to the man of the hour. Greg, thank you so much for being here and for talking with our audience.
Awesome. Thanks, Mike. I appreciate it. And hey, good morning, all. As we get into the presentation here today, please stop and ask questions. If we have to spend the next 60 minutes just listening to my monotone voice drone on, it's going to get challenging for all of us. So let's feel free to be interactive as we go through. On the next slide is we've been working with Mike and the great folks at the Pittsburgh Business Group on health. They continue to ask and challenge us on how we really do a better job of explaining what's happening in the PBM industry so their members and you all as purchasers can make better decisions moving forward. And so what we've put together is to say, hey, through these kind of 3 1-hour sessions, we're going to try to break this very complex world of PBM down into a couple just key objectives for each one that hopefully hit some of the largest challenges that everybody is seeing. And then we've got some examples also to really try to go through and explain the problems that exist, why PBMs make decisions typically that they make, and how purchasers should be really asking questions of both their PBM and frankly their consultants to make sure that from a fiduciary standpoint, they're doing the right thing by their members, but also just from a global standpoint, I think there's a lot of money that could be saved, a lot of members that can afford their drugs, and we could really help improve healthcare overall for people with just a couple small actions. So for this first session that we're going to cover today, there's a huge conversation around rebates in America. I was on Capitol Hill, Washington, D.C. again on Wednesday, meeting with 5 different congressional staff's offices. Rebates came up in every single conversation, almost always is the first point, trying to figure out how we fix this rebate issue in America. Then talk about what questions we feel payers should be asking their PBM to make sure that they are getting the proper benefit, the right drugs are being covered, you guys are seeing the right costs then associated with that in a way that makes it more affordable. And then lastly, really it started in 2018 when Cigna bought Express Scripts, United Healthcare and Optum as a healthcare and PBM have been put together, but now United Healthcare owns 5% of all physicians in America. You've got CVS, which is a PBM. They own Aetna, the health plan. They own all the retail stores. They own a mail and especially. And so we've been told for, again, 5 years that this horizontal and vertical integration is going to help drive down cost and improve quality. But every year since we really got deep down this road, costs have gone up and healthcare outcomes continue to drop. So I think we've seen the results of why vertical and horizontal integration is bad, but we'll talk through some of the examples that we specifically see that equate to that. So going on, as we really think about rebates, I think it's important to take a look back to understand how we got in the situation we're in. I promise I'm not going to try to do a bunch of slides with numbers on every or every slide that we've got, but as I look at the presentation, there might be a lot of that. So I'll do my best to talk through it in the least painful way possible. But if we look at this kind of whole rebate, I think, phenomenon that has really started to take hold, it was back in 2012. If you think back, that was only about 10 years ago. We didn't have any high-cost specialty drugs. So the concept of specialty drugs did not exist anywhere. We were simply brand and generic drugs. And if we had an employer who had a $700 brand drug, I mean, they were absolutely freaking out. Like, oh my gosh, $700 for a drug? Like, how can we afford that? We also had, about 8 regional PBMs. So there was a lot of competition among the PBM industry. If you think about total percent of spend within all of healthcare, pharmacy was only about 8 or 10% of spend. So not a big part of spend, no specialty drugs, lots of PBM competition, wide open formularies, because the formulary is really what drives the whole rebate structure. And so, the PBMs were only getting about a 3%, call it rebate. And when we say rebate, we use that term because I think the industry likes to use the term rebate. But the real thing is rebate equals all manufacturer revenue. And so when we really think about a rebate, it's all of the money pharma's putting into the system, not necessarily all of the money payers are getting back out in the rebate term that the PBMs use. But pharma was paying about 3% total rebate. So if you think about, cost of the average brand drug being $500 in 2012, pharma's paying 3%. So you can see there's a total $15 being paid to the PBM from the pharmaceutical manufacturer. So then that net profit back to pharma for that drug was about $485. So then if we fast forward 3 years, then we get to 2015. We're just now starting to see some more of these really high cost and specialty drugs start to hit. We're seeing a little consolidation from 8 to call it 5 PBMs. PBMs are starting to use the formulary to say, hey, like if we just use Humira and Enbrel as an example, AbbVie makes Humira, Amgen makes Enbrel, and so they started tiering these drugs. So that's really when we started seeing all of these multiple tiers hitting the plan benefit. And so, they said, one of you guys is going to be, call it tier 1, one of you is going to be tier 2. Whoever's tier 1 is going to have to pay a larger rebate to us as the PBM to get on that tier. So that's how we got from a 3% kind of total manufacturer rebate payment in 2012 to 10% in 2015. Now the average cost of the drug's up $600. So if that 10% turns into $60, then pharma's still making $540. So not bad for them. 2018 is when things started really getting crazy in this rebate world, because now we've got all of the consolidation down to 3 main players in the PBM space, and Optum, Express Scripts, and CVS is the PBMs. We've got a lot more high cost brand and specialty medications hitting the market. And now we've got the concept of exclusionary formulary starting. So now instead of saying, hey, one of you guys, Amgen or Enbrel, is tier 1, one of you is tier 2. Now it's an all or nothing. So they could extract more money out of the manufacturers because the manufacturer knows if they don't pay up in these rebate dollars, they will lose access to tens of millions of lives. Because if you're not on formulary, you're never going to sell your drug. So now we're seeing the rebates balloon up to 25%. Average cost of a drug is up to $750. So you can see that rebate going to the PBM is about $190. Profit to pharma is $562-ish. Then by 2021, things are getting real crazy. Rebates are 40%. They continue to extract more and more out. So, the cost of the drugs, because pharma is having to pay way more in rebates, they're massively increasing the front end cost of the drug. And so everybody is always saying pharma sets the price of the drug. They're the problem. And my contention is that's not completely accurate. Because again, from 2012 to 2021 in this scenario, yes, pharma doubled the cost of the drug. So that upfront price went from $500 to $1,000. But pharma, what they saw out of that, they only increased their kind of net profit by 22% over 10 years. So pretty moderate in corporate America. The PBMs, though, increased from $15 to over $400 per claim. That's a 2,600% increase. And again, if all of those rebate dollars and manufacturer dollars were going back to plan sponsors and patients to help buy down the cost of drugs, I think we've got a very useful and relevant healthcare marketplace. But now that pharmacy is about 33% of total spend, we have these rebate aggregators that PBMs have created that don't ever show you what you're actually getting back in a claim level for rebates, and they're making tens of billions in profit off of this system. That's why rebates are a problem. because we just don't see actually where the money's coming or going from. So just for some historical perspective there. Outside of the rebates, just on the next slide, the other thing that we see if we track the profit of these pharmaceutical manufacturers over time is in 2012, you can see, again, a lot of money was being made by the PBMs and rebates. So what this slide is showing is of all the profit the manufacturers are making, what bucket is it coming from, whether it's rebates, spread, fees from the GPOs, their mail order, or their specialty pharmacy. So the rebate in 2012 was a big part of it. You can see now through 2023, it's a much smaller part. But what they've done is that fees part, so the little 5% box in 2012, that's now grown to 22%. You can see from a specialty pharmacy standpoint, that was only about 16% of their profit in 2012. Now it's almost 40%. So again, that's the vertical and horizontal integration, because when the PBM owns the specialty pharmacy and the mail order pharmacy and the GPO and gets to decide all of the funds that go through there, yes, everybody's kind of pushing down and saying, well, PBMs don't make as much on the rebate anymore, but they make significantly more in these other buckets. Now, the interesting thing this slide does not show is the pool of money associated with all of these. Because in 2012, you were talking hundreds of millions of dollars for that entire vertical. By 2023, this vertical is close to $200 billion. So it is a significantly bigger pie that they're pulling all of these profits out of. But once you know where they're pulling their profits from, then it helps us understand where to really look so that we can hopefully add a better value back to our plan members. So to get very tactical on the next slide and talk through this, I'm sure many of you have seen this. When you do a RFP for PBM services, you hire a consultant. Consultant then puts this whole crazy spreadsheet together to say, here's PBM 1, here's PBM 2, PBM 3, PBM 4. And they say, hey, which PBM do you want to use? And so this is just a sample that we pulled out from a consultant that we had done some work with to say, you can see your retail 30 brand guarantee, your retail 90, that kind of 84 plus brand guarantee, mail brand guarantee, and specialty. Now, a couple things here that everybody should be aware of. Manufacturers do rebate contracting basically based off 30-day increments, and they don't care if it comes from a retail pharmacy or a mail pharmacy. They just say, hey, PBM, for every 30-day supply of my drug that you dispense, here's what I'm going to pay you in rebates. So one, if you look from the top column, and I'll just focus on PBM number 1, that $160 for the rebate guarantee on the 30-day supply, that 160 times 3 is $480. So if you were getting all of the 30-day increments, that retail 84 plus and the mail should both be the same, because that's what the PBM is paying out. Now, knowing that there's a much smaller percentage of claims that hit that mail, it's interesting, the mail order guarantee is $630. So what that tells me is the PBM's probably getting, about, call it $210 at a minimum in rebate guarantees. And then when they put it on this form, though, that $160 at the top for the 1 to 83 day supply, they're really getting $210 at least there, and they're only passing 60 through. Even on the retail 84-day supply, that should still be $630. So there always should be the same rebate number between the retail 84 and the mail, because that's how the manufacturers contract. You can see PBM number 4 on the far right has the exact same amount, that $491.37 for both the retail 84 plus and the mail order. That's what you should really see in your rebate agreements, is the exact same amount. And then that amount should be a third on the top column. So I'm not exactly sure what this PBM's doing with a $24.58 rebate for the 1 to 83 day supply. But again, it's simple math just to say a 30-day supply is this, anything 84 plus should be 3 times that for brand drugs. But you can see these discrepancies all over the place. They just don't make sense. But then at the bottom on that specialty per brand guarantee, you can see PBM1 is $1,500 and PBM2 is $2,500. So if your consultant comes to you and says, hey, which PBM do you want to go with, PBM number 1 or PBM number 2? Feels like kind of an obvious answer, right? Like, well, duh, I'd rather get that $2,500 specialty rebate and not a $1,500 specialty rebate. But if you notice, this does not say a 30-day supply or a 90-day supply of a specialty rebate. It just says specialty. And so that can cause a real problem. And so this is something you really should look at, especially in your claims data today as you're working with your consultant and your PBM. Because on the next slide, as we go through, if you allow the clinical criteria to drive your decision making, which you should, in our opinion, all of the clinical criteria that exists on specialty today says specialty drugs should only be filled in 30-day increments. And that is also how pharmaceutical manufacturers are paying rebates in 30-day increments. But this is real data that we got from a client that we were doing some work with. And basically what we found is that in this little chart off to the side, you can see at the top, there was 336, and this was Humira prescription claims that were 30-day supply or less. There was 91 Humira prescriptions that were filled as a 60-day supply, and then there was 283 Humira prescriptions filled as 90 days or more. So when they fill that 90-day supply of Humira, that's 4 times a year they're filling that. Well, according to their rebate contract, they're paying you $2,500 per fill. So then that means you're only getting 4 rebates a year at $2,500 versus 12 if they were doing it in 30-day increments, is the clinical criteria really shows. So in this scenario, we said, so if you get 710 total rebates at the top, at $2,500 per specialty rebate, you're getting that $1.775 million. Well, at the bottom, though, that PBM is following proper clinical criteria. So their rebate guarantee as a per claim is got to be smaller, and they know that. But again, on the spreadsheet, if you just focus on $2,500 or $1,500, I mean, everybody would pick 25. What we don't talk about is what you're actually getting in total rebate dollars paid. So for that PBM, if they would have done it in 30-day increments, you can still have 336 fills at 30 days or less. And then, at the top where that PBM was doing 91 60-day fills, that would actually turn into 182 30-day fills. And then the 283, 84-day supplies or more turns into 849 claims. So you would actually be getting 1,367 rebates paid to a year as opposed to 710. And you're actually netting out over $2 million in rebates in this scenario. So we really need to be thoughtful to say, okay, so the PBMs do play a lot of games on the back end. Why are we not talking about how much you're getting in total rebate dollars versus talking about a fictitious rebate amount of $2,500 that turns into some random thing at the end based off of how the PBMs are playing these games? Any questions about that so far? Okay. I think this rebate example is a good step into our next slide, because you can see, in my opinion, this whole industry is complex by design, right? And I've joked for years that mantra of the average PBM, that in chaos there is profit, and there is a ton of chaos in the system. So this is just a little kind of illustration we put together on, you can see flow of funds, flow of drugs, flow of services, and there's lots of boxes, lots of money moving around. And then usually in that bottom left-hand corner is where the ultimate self-funded plan sponsor sits. And they're kind of at the mercy of almost everybody else in the system. So as we've looked at, where copay dollars go, premiums go, share of rebates for manufacturers, what we do know about some of these different boxes on the next slide is that pretty much everybody makes their profit as a percentage of revenue. So what that means from a manufacturer standpoint, right? If the manufacturer is making 10% and they increase their drug costs, that 10% turns into a bigger number. So higher cost drugs is higher profit for the manufacturers. Wholesalers, they charge a percentage of the cost of the drug to carry and distribute these drugs all around the country. So the higher cost drugs they can carry and distribute, the more profit dollars they're making, good for them. PBM, same thing. If they can make 10% off a $5,000 drug that they put on formulary versus 10% off a $50 drug that they put on formulary, they would much rather have 10% of the 5,000. So drives to poor decision making, in our opinion. It's always driving up costs. But then at the bottom, you've got the employer, the public purchasers, the plan sponsors. Those high drug costs equal lower profits and frankly higher premiums for the rest of the plan. So it is really a system that's out of alignment, in our opinion, because the poor employers and public purchasers really are beholden to the PBM, the wholesaler, and the manufacturer to supposedly make decisions on their best interest. But because these industries are all run by for-profit companies who are looking to maximize profits, it's always about driving to a higher drug cost, again, at the detriment of the employer and the public sponsor. So we've hit some of those rebate pieces, really talked through some of the complexity in the industry, and here on this slide, what drives the decision making. Now let's go through some more examples to really play this out. As I was talking about in that 2012 to 2015 to 2018, in 2012, there was no specialty drugs. The first really, really expensive specialty drugs that came out were these drugs for hepatitis C. They started coming out really in that 2013, 2014 timeframe. And again, people were already getting upset about having to spend $700 a month for a brand drug. And now all of a sudden you've got these hepatitis C drugs that were over $100,000 and the market just almost imploded. Everybody's like, how is this going to work? Which really rich today. Now we're looking at $3 million drugs being approved that we're trying to figure out. So 100,000 doesn't even feel bad anymore. Again, that's how fast this market has changed on us. But say back in 2015, we've got these $100,000 drugs. Gilead was the manufacturer of these who came out with their drugs first. And their concept was moderately useful in the fact that if you have hepatitis C, in 5 to 7 years, your liver is going to burn up. And either you're going to need a $1.2 million liver transplant surgery or you're going to die. So pretty bad, outcomes if you don't do anything. So if we put this drug in the market, we charge $100,000 and it cures you of your hepatitis C, completely cures you of it. What's that really worth? And so that was part of the, driver for them to come up with these costs. But as we sit here today, now we've got multiple manufacturers, multiple drugs that cure hepatitis C. You can see Harvoni, Epclusa, Vosevi are all Gilead products. Harvoni was the first one that came out. There's actually, not to get super technical, but there's 6 genotypes of hepatitis C. You can see Harvoni only worked on genotype number 1, 4, 5, and 6. If you had genotype 2 and 3, it did not cure you. So if the physician didn't do a proper genotype testing, gave you a $100,000 drug and you had one of those 2 genotypes, you actually weren't cured. So, that wasn't great. And you had to take the drug for 12 weeks to get to a cure. So one pill, 84 days for $113,000 to cure you. Well, then they came out with Epclusa and Vosevi. Those worked for all genotypes. So now we didn't have to genotype test. You still had to take the drug for 12 weeks, but we dropped the price down to call it $90,000. About 2018 then, AbbVie came out with a very competitive product, Mavyret. Again, works for all genotypes. You only have to take this drug for 8 weeks, so a month less to cure, and it only costs $31,000. So if you plan sponsors, you get to make a decision on what drug ends up on your formulary. And if you talk to a physician or a provider who sees patients with hepatitis C, and you say, first, let clinical criteria drive the decision making, knowing that adherence is always a big concern and challenge. Doctor, do you want to give somebody 8 weeks of drug to cure or 12 weeks of drug to cure? And I think 100% of the time, the physician is going to say, if you can cure in 8 weeks, do that, because you're more likely to make sure the patient's adherent for 8 weeks than they are for 12. Then if you look at the cost, well, drugs at third as much. So 8 weeks, a third the cost, 12 weeks, 3 times the cost. What drug do you want on your formulary? And again, kind of like that rebate, do you want to get a $2,500 rebate or a $1,500 rebate? On the front end, it seems like an obvious answer. For us, it's an obvious answer. We would cover Maverick because it's clinically superior at lower the cost. But on the next slide, if we look to see what the CVS formulary says, and we just are randomly picking on CVS, this is their national formulary, but Optum, Express Scripts, other PBMs have these exact same formulary things in there. You can see I love it for that formulary drug removal. Get Maverick off of there. Who wants that? Nobody wants the $31,000 drug that gives you a cure in 8 weeks. Here's your formulary options in Epclusa, Harvoni, and Bosevi. So just one example where it is very clear through formulary decision making that these large PBMs are driving to the highest net cost drug where they can, because they're removing the clinically superior, very low cost product. Like, that shouldn't be on formulary, right? Let's have the 12 weeks really expensive drugs on formulary. The other thing that I think is important to note here is you can see Epclusa, Harvoni, and Bosevi, right, from the last one. They're all made by Gilead. So Gilead likely went to CVS to say, hey, yes, it's $90,000 or $100,000 for these drugs, but I'll give you a 63% rebate for putting these drugs on formulary. So the rebate alone for them is going to be about $55,000, which is almost twice the cost of Maverick. So that the PBM now knows they're just going to get $55,000 just in rebates for these drugs. And in your same kind of plan document, even if they dispense 3 of these prescriptions once a month for Epclusa, Harvoni, and Bosevi, at that kind of back to that $2,500 per claim example. So you're going to get $7,500 in rebates, right? Because you get a specialty rebate guarantee, and every time the PBM pays for a specialty drug, they're going to give you $2,500. And Epclusa, Harvoni, and Bosevi are specialty drugs. Here's your $2,500, so $7,500 to buy down the cost of this $90,000 drug, knowing the PBM took probably $55,000 in from Gilead for these drugs. And that's then a huge bucket of money that the PBMs can either keep as profit or use to smooth other things out and play other games and hide more money in the middle. So again, it's rebate decisions, which drive formulary decisions, which increase costs for plan sponsors and their members. Again, any questions or thoughts about that? Okay. So on the next slide is we think about, again, the concept of vertical and horizontal integration. This is just kind of a mess, right? But again, we do live in this world where the insurer, the PBM, and then the GPO is listed here because that's really the entity that makes the rebate decisions on behalf of, frankly, the PBMs now. And then these same verticals own specialty pharmacy. They own the doctors, like we talked about earlier with United Health Group now, owning 5% of all primary care doctors in America. Do we really believe that this is a really good way to, get better outcomes at a lower cost? Because in general, it sounds like it should be, right? Like just picking on Cigna, the insurer, if it's fully integrated with Express Scripts, the PBM, which is fully integrated with Accredo, the specialty pharmacy. It does seem like they should share data. They should have similar policies and procedures. They can coordinate care a lot better. They can do things to drive down costs. So that was the hypothesis that we were supposed to believe. But I think we, again, through the last 5 years, since all of this has really played out, we continue to see the costs go up and the quality go down. And then the GPOs that were created, there in the middle with Zinc, Ascent, and MSR, they were created for a very specific reason. And so Ascent, the one with Cigna there, which is the little like mountain, the reason that they really created these GPOs was back in, call it 2016, 2017, 2018, there's a couple things going on. One, employers had in their contract with their PBM that they should be able to see the contract between the PBM and the manufacturer, so they could say, hey, PBM, how much money are you getting from the manufacturer? And then am I really getting the fair share that I think I should be getting? Additionally, there was a lot of state activity, mostly occurring, some federal talk about how much money was being made in rebates, and the fact that we really should put rules and laws around there to make sure that people actually know all of the money the PBM is getting, and then is the right amount going to the plan sponsored payer. So ESI started this, and their concept was, okay, so Express Scripts on that line is a legal entity. That legal entity, right, has the contract with the employer and also the contract with the pharmaceutical manufacturer. So they called all of the manufacturers into their corporate office in St. Louis, and they said, hey, we're canceling all your contracts right now. So now Express Scripts, the legal entity, no longer has any contracts with pharma. We've started this new company called Ascent. We domiciled it in Switzerland because that makes sense. And now, Pharma, you guys have 6 months to recontract all of your commercial agreements for self-funded payers with Ascent. So that did two very specific things that benefited Cigna and Express Scripts. One, now in all of the Express Scripts contracts where it says, hey, you plan sponsor get to see all of the contracts that Express Scripts has with the manufacturers. Well, they don't have any contracts anymore, right? They're this legal entity. Ascent is a separate legal entity, and they're always like, hey, there's this firewall between us and Ascent. So, gosh, when you know what? I don't even know what Ascent's contracts are. They just pass this money to me, and it's great and wonderful, and you'll love it. But, it was just a new legal entity that they could use to obscure and hide a bunch of data. The other thing it did for him is it gave him the ability to start adding a bunch of GPO fees. So then if the manufacturers were giving $1,000 to Express Scripts and they gave the same $1,000 to the GPO, well, now the GPO can take a 5 or 8% GPO fee. And so they started taking all of these additional fees. So, of course, CVS watched Express Scripts do that. They're like, oh, that's brilliant. So they started Zinc, their GPO. Optum was a little slow to the table, but they caught up pretty quick, and they said, well, we'll start our GPO, MSR. So I love MSR. Somebody looked this company up. We were actually working with a Wall Street Journal reporter on this. MSR, we're guessing, is going to probably bring in, as we look at Optum's own financial earnings, about $60 billion this year. So just that little MSR square on the far right is a $60 billion entity. Nobody can find it online. Can't find any employees that exist anywhere on LinkedIn for these companies. So how is there an organization this big that's supposedly driving some unique value to drive down costs in America that you can't find anything about? And again, it's literally just a paper-based organization that helps them convolute because it's a separate legal entity, even though it's just a shell. And the people who are already contracting for Optum still just contract for Optum. Now they just have an extra set of paperwork between the manufacturer and Optum through this kind of industry organization called MSR. So again, we're going to continue to see more and more of these boxes hit because it allows them to move money around. It allows them to play legal games with definitions on what one entity can see versus another, and then, how they, again, hide a lot of money. But beyond that, if we were to just stick with Optum, because they're kind of the cleanest on this slide, Optum also owns its own specialty pharmacy. And so then Optum, the PBM, gets to make a decision on what it pays the pharmacy. And one of the other kind of great industry things that has been coming up is, Optum, and in this case, I'm not just picking on them, right? So whether it's Evolance, Humana, Cigna, CVS, Centene, any of them, employers have started coming to them to say, hey, not only do I want 100% of rebates, so I feel better about that, which, we've gone through and figured out that there's a lot of money being kept in the rebates, so that's not great, but I want to pass through contract. Like, this concept of spread pricing is bad. We don't like spread pricing. Don't do it anymore. So, they played the game. They said, okay, fine, we won't spread you. So what pass-through means is the PBM decides what to pay a pharmacy. Whatever it pays that pharmacy, then it charges the plan sponsor the same amount without marking it up. So what would usually happen is, right, if it's an amoxicillin prescription, the PBM would decide to pay the pharmacy $10, and then they would charge the plan $15. And so then there was this $5 in spread that was created that was profit for the PBM. So employers increasingly got, attuned to that. So that's where they started saying, hey, no, we're not doing the spread thing anymore. We want to pass through. And now these PBMs are offering these pass through contracts. But if you also remember on that slide where we talked about the profit buckets of the PBMs, from 2012 till the end of 2023, the biggest increase in profit for these large vertical and horizontally integrated companies was out of their specialty pharmacy. And the reason that is on the next slide, we'll talk through again a very specific real life example that occurred. So there was a hospital. It was a multi-hospital system, frankly. So this is a large health system. And we, again, did some work with them. And at the bottom is where the health system filled prescriptions for this drug called tadalafil. Very common specialty drug, just so you know, the hospital's acquisition cost on this drug was about $10. So the hospital pharmacy is sitting there, right, from the pharmacy budget line item saying that they're getting $190 reimbursed from the PBM, and they think that's great. And then, of course, then the health plan is being charged that same $190. Well, when the exact same drug for the exact same strength from the exact same manufacturer. So these are both, I think Teva was the manufacturer of tadalafil, and both at the top, the PBM owned pharmacy was dispensing Teva. The non-PBM owned pharmacy, which was the hospital's own pharmacy, was dispensing Teva. So again, same acquisition cost, same drug, same list price to buy it, everything. Well, but when the PBM decided what it paid its own specialty pharmacy, all of a sudden they were paying it $3,856. Now, again, in that concept of a pass-through contract, because they were taking the $3,856 that they paid the specialty pharmacy and they charged the plan the exact same amount, hey, good job, right? Pass-through contract. We didn't mark anything up in the middle from the PBM standpoint. All they did was bury all of those additional profits over in the specialty pharmacy, which of course they fully own and control and drives to corporate profitability, and did it in a way where they're trying to make the market feel good about itself. But again, we do continue to see people say, hey, if you get drugs from my own specialty pharmacy that I, the PBM, own, or my own mail pharmacy that I, the PBM, own, it'll drive down costs. And that's actually not at all the case. The other very interesting game that we're seeing that you should probably ask your consultant about is it came out of Express Scripts, I think was the first place that we've seen it, but now we've noticed it out of numerous other mail order pharmacies, is they're doing auto refill of brand prescriptions every 26 days. So every 26 days, if you're on a brand prescription for, like, call it Advair, they just send you another 30-day supply, 30-day supply, 30-day supply, 30-day supply. So then they say, hey, look, adherence for our patients is so good, we're 100% adherent. Well, the patient never asked for those drugs. It's just automatically being shipped. And we're seeing a lot of patients starting to say, hey, I've got all of this extra medication at home. I don't want any more. But literally, they can't shut it off. Like, once you're in this mail order system, it just keeps coming. Well, the reason these PBMs like 26-day supplies is because then you can actually fill that prescription 14 times a year. So then instead of billing for 12 prescriptions a year, they're actually paying 14 prescriptions a year for a lot of these brand drugs. Now, of course, they like that in specialty too, because the more they can, send these out, they get a high cost. It drives more rebate dollars. But you really should talk to your PBM and consultant to say, hey, like, what's the days of supply you're actually auto-filling these prescriptions for? And by the way, do you ever talk to our plan members to see if for some reason they already have too much of this drug at home and they shouldn't get any more? And is there an easy way for them to turn it off if they're in that situation? So, because the answer is no. I mean, once that machine starts filling these prescriptions, it is almost impossible to turn it off. So again, I think this kind of concept that mail and specialty is actually of lower cost is completely debunked, and you can see it in the massive profits that are coming out of those entities that are, again, owned by the PBM and the insurer. Another example on the next slide that we continue to see is we've got a pretty close relationship with Mark Cuban and his Cost Plus Drug Company. We really like him. he's a public benefit corporation. So the Mark Cuban Cost Plus Drug Company is not trying to maximize profits for itself. It's also trying to do as much good for as many people as possible. And what Mark Cuban does with his pharmacies, he buys drugs and he puts the invoice out online. So you can actually look and see the exact invoice that he's paying. So everybody knows exactly what he's paying for drugs. He's marking up the cost of that drug 15%, which, just for perspective, Walgreens, retail pharmacies like Kroger, Walmart, their pharmacies are probably making a 2 or 3% margin. So very, very low margin here. Cuban's making a huge margin of 15%. I mean, it's a big number for pharmacy margins. But like this top drug, imatinib, he can sell it then out the door for $866 a year. That same drug, and we've looked at state health plans for Kentucky, Tennessee, Georgia, and Louisiana. Of note, all 4 states use CVS as the PBM, so it's the same PBM. These state health plans, like the state of Kentucky, is going to spend about $600 million on just their pharmacy benefits for state employees and dependents. Tennessee is $750 million. Georgia's $1.4 billion a year just with CVS PBM. So, again, we continue to hear this, like the largest employers get the best deal and everything. Well, these are the largest accounts that you can get. And so what decisions is CVS making for each of these different accounts? Well, that same $866 imatinib drug through Mark Cuban's pharmacy in Kentucky is $26,000 a year. But unfortunately, if you live in Tennessee and you're a taxpayer there, for some reason, it's $212,000 a year. So one, it's really bad, in my opinion, that these drugs are different costs between Kentucky and Tennessee, right? Why would there be such disparity for the same PBM for a similar size group? These employees and dependents are very similar demographics too between Kentucky and Tennessee. And yet the cost disparity is ridiculous. And they play this game over and over again where the cost of the drug is never the cost of the drug. It's always variable and nobody's really paying attention to it. But then, 2, this is why those specialty pharmacies are creating such huge profit pools for the overall PBM and its corporate entity, because they get to decide what they pay themselves. And Tennessee's got a pass-through contract. So the PBM sitting there saying, hey, I paid the pharmacy $212,000. State of Tennessee, I charged you $212,000. IPBM didn't make any money in the middle. Look what a great partner I am. But they could move all of these prescriptions over to, of course, Mark Cuban, his Cost Plus Drug Company, and you can see they would save a bunch of money. Now, this is an extreme example. If you get out your microscope once you guys get this and look at all the other ones, we did do the highest cost drugs or the highest volume drugs too. So, and across the board, whether it's what should be a low-cost generic or not, the price disparity between Cuban and all 4 of these different states is pretty extreme. So this is not just a random example that we found, that we picked out, that somebody could say, well, that's a total one-off. Well, there's 24 more examples, whether they're specialty drugs that are really, really high cost, because then the PBM can say you can only get it filled at my specialty pharmacy. That's where the really big price discrepancies occur. Or across the board in any of these other ones, you can see there's still a lot of cost increases between Cuban and what CVS charges these states. So it's crazy all over the board how you look at it. That last kind of real game I'm going to talk about from a corporate entity, vertical and horizontal integration standpoint. So there's this concept that's coming out in some of the federal legislation, but certain states are also looking at it as well, because now people are saying, look, CVS is making $212,000 out of this drug that they're probably buying for, call it $400. That is an extreme profit margin. We want the specialty in the mail pharmacy to start like really telling us how much they're making in profit margin, because we think that's now getting out of control. So we're starting to see potential legislative action being put in place to try to minimize these practices, or at least if these practices exist, they say, well, what did you pay for the $212,000 imatinib? Are we okay with a 4 million% profit on this drug? Yes or no? Well, again, Express Scripts in their evil genius, they usually lead. So what they did is they said, okay, so right now CVS, the specialty pharmacy, is going to a wholesaler to buy this imatinib for $400, right? Well, if I put an entity in the middle and I say, okay, this new entity is going to buy from the wholesaler. So it's going to go from wholesaler to new entity to my specialty pharmacy. And then I get to decide what this price markup is. Then we can make it look like we're paying a bunch of money for these drugs. If somebody comes knocking on my door to say, what are you really buying these drugs for? It's like, no, I mean, look, I paid $200,000 for this imatinib. I only charged you 212, like as a percentage. I didn't make that much on it, right? So Express Scripts led with that. So on the next slide, this is one of my favorite things ever. Express Scripts started Quallent Pharmaceuticals. It's a wholly owned subsidiary of the Cigna company, as you can see. It doesn't even show up on that vertical map that we showed earlier. They just started this. We've asked Mark Cuban's Cost Plus Drug Company to reach out to Quallent twice because they say you can buy drugs and we're this great distributor. Nobody ever answers. But if you go to the Quallent Pharmaceutical website, their address, as you can see there, is in the Grand Cayman Islands, right? Every good business starts and ends in the Grand Cayman Islands. I'm sure there is a tremendous amount of pharmaceutical supply chain expertise in the Grand Cayman that helps them really maximize the value that they're bringing out of Quallent Pharmaceuticals. But again, I think it just clearly shows here's another corporate entity that's going to fall into that massive vertical of all of the other corporate entities that are known as Cigna, which I think at last count, there's something like 750 different entities that make up the Cigna Corporation. And the way they can play these entities against each other is just, again, it's not to make the system more efficient. It's not to drive down costs. It's to convolute and bury profit in other places where they know people haven't started to look yet. So just another challenge that we're seeing that we know is coming up based off of industry pressures that these guys are seeing. They started a company in the Grand Caymans. Like, it's just absolutely egregious at this point in time. Last then example to really kind of go into, again, closing on why rebates drive higher prices. So something that I think you guys can look at, because we see in pretty much every claims file that we look at, is Descovy and Truvada. So if we think about what these two drugs are, and you can see here, so basically that the story is in 2009, and again, I feel like I'm picking on Gilead. I'm really not. This is just another Gilead product. Gilead, the manufacturer, came out with Truvada. And what it really was is they took two active ingredients for two different pills that people were having to take, and they put it into one pill. So it's, now you can kind of get two pills in one. FDA liked it. They approved it. Again, started selling it in 2009. Well, 2020, they lost the patent on it and it became a generic drug. So before they lost the patent on it, they got the FDA to approve a similar product called Descovy. Descovy is literally the exact same two active ingredients. The only difference is they changed the salt, so the chemical structure a little bit on the second active ingredient. And if you read the clinical criteria for Descovy, it literally says from the FDA that it might work better in people with late stage renal disease or osteoporosis. So late stage renal disease, osteoporosis, it might work better. For everybody else, Truvada is probably a superior product. Well, Descovy and Truvada are on the market to treat HIV PrEP. So if you think of the 2.4 million people in America who live at high risk for HIV, who should be taking these drugs for prophylactic reasons to not get it, and you think of then the same type of people who in your mind would have late stage renal disease or osteoporosis, I don't see many, call it 72-year-old white ladies, really needing HIV PrEP. I know there's not 2.4 million of them living in the villages down in Florida. Like maybe, that specific population might need it. But outside of that, it is not really a Descovy driven world. But if you look at your claims criteria, you're probably getting we've seen about 60% of the claims go on to Descovy and not Truvada. And so the real question is, on the next slide, if you are an employer, do you want to pay $23 a month for Truvada as a generic drug? Now, you don't get any rebate, but you're paying $2,300. Or do you want to pay $2,200 for Descovy? Then the PBM gets about $600 in rebates from Gilead. They keep 100 of it. Then they come to you and say, hey, I use my size and scale as this great PBM to drive down the cost of the drug. So here's $500 in rebates. Now your Descovy only costs $1,700 a month. And again, they can put that on that spreadsheet going back to that $2,500 to $1,500 world and say, look how much this great rebate I'm giving you from a mail and a specialty standpoint is. but your net costs are still extremely high. The other problem we have with this, if you have a high deductible or co-insurance plan, now your member's responsible for a percentage of $2,200 versus a percentage of $23, knowing that they're taking this product more for prophylactic reasons. Significantly more people who take Descovy are non-adherent because the cost is a barrier to them taking their drugs. So, across the board, these bad rebate decisions, because rebates are driving formulary design is driving usage. That's why you're going to probably see 60% of your usage or more being gone to Descovy versus, the very, very low cost Truvada. And by the way, if you are even getting the generic Truvada and it's coming from a pharmacy owned by your PBM, I would bet your cost on that claim are still $1,000 to $1,500. So again, there's just all of these costs built into the system, and it just drives massive increase in costs for you and your members, and it's very bad for the system. So, kind of in closing, what we hope we talked through today is if you focus on rebates here, you might end up with a Descovy. So even after rebates, you're having to pay a plan cost of $1,700 a month versus a low cost $23 for a generic. So rebates are not good. Here's some questions you can ask, like percentage of Descovy to Truvada, really looking at your formulary design. So are you seeing like Epclusa, high cost drug that's got really inferior clinical outcomes at 12 weeks versus a Maverick, which is better at 8 weeks and a third the cost? What does your PBM charge and pay call it a Truvada prescriptions from a pharmacy that it owns versus a pharmacy that it doesn't own. So really start trying to dig into where the PBM's paying itself and retail or other independent pharmacies. Are those costs similar or different? More often than not, you'll see a much higher cost at the PBM's owned asset. And then again, as we think about vertical and horizontal integration, the more different entities that they can put under their corporate umbrella, it allows them to try to tell this market-driven story on why they're doing good things, when in reality, they're just driving up corporate profits for themselves and their shareholders. Again, at the detriment of their client and their client's members, in our opinion. So with that, I know we've got 5 minutes left. I know I was asking for questions and you guys were all muted, so sorry about that. I do see one question in the chat that the big three continue to shell games. Yes, and they're making enormous profit. Totally agree. Any other questions or thoughts that we want to cover? All right. Well, Mike, thank you very much for the invite to do this. I hope that was information that the group's going to find useful. Appreciate that, Darren. Thank you. I know that the presentation will be shared with you guys after the fact. And if you have any questions, I know that great folks at PBGH and ourselves are always here to answer anything else that we can. Very complex topic, again, by design. So we really think the more everybody knows about it, hopefully the better decisions they can make on behalf of their plan and their plan members. Awesome.
Thanks so much, Greg, for all the information. Super appreciate it.
You're welcome.
And just wanted to let the attendees know for the next two coming up on the 1st and 15th of December, you can use the same link that you used today to join those webinars as well. All righty. Feel free to reach out if you have any more questions, and have a great weekend, everybody. Thanks, Greg. Thanks, Kristen.
Yep. Thanks, Annie. You guys do the same. Take care.
Thanks. Bye-bye.
Bye.